هذا فيه بعض المحاضرة. الأهم البيزكس stuff اللي I mentioned about reading an ECG لأنه that's what will build up your knowledge to ECG. النولج حق ال ECG ما حيجي من محاضرة واحدة ولا اثنين ولا ثلاثة. It will be built up throughout the years. The more you read ECG, you'll make mistakes, which is okay because you're in the training phase. That's fine. But at least if you learn 1 point from each ECG you read, that's an achievement. If you know now in the ECG, a large box is 20 seconds, 20 milliseconds, or 0.2 seconds, that's enough for me. That's enough that you know the basic of ECG, knowing the localization of an infarct. So this is just a prime to the world of ECG. طبعا في a gazillion book that you can read. I can recommend the only ECG or the only EKG book you'll ever need. It's a good prime book for medical students and intern. And then if you dig deep into the field or you become a cardiologist, you'll obviously need more sophisticated books. طبعا my email and my Twitter account are readily available. If you need any information, if you need extra sessions, I'm available. بالعكس, I'm passionate about teaching. I'm hoping that I can teach something that you will benefit you for your career. So when you go into cardiology or you go into any different specialty. طيب. Common arrhythmias, we're going to focus on probably 3 common arrhythmia that I want you to know hard. And this arrhythmia, I want you to know the bread and butter about, because this is the most common arrhythmia that you're going to see in your clinical practice, and you're going to deal with it. If you are a cardiologist, you're going to treat. If you are an obstetrician, you're going to treat a patient with such an arrhythmia. If you're an orthopedic surgeon, you're going to treat a patient that comes to your OR with similar arrhythmia, and at least you know the basic, when to call the cardiologist, and is this normal or abnormal. So it is very important to know. I'm going to start with the most common, from the atria going down. Atrial flutter, it is an extra wire between, just to make it simple, it's an extra wire between the atria and the ventricle, making an extra connection between the atria and ventricle. And in certain situation, the conduction that might happen through the normal rhythm, which is sinus node goes intra-atrial tract into the AV node, and then from the AV node goes into the bundle, from the bundle to the left bundle, and then left anterior and left posterior vesicles, or to the right bundle, and conduct the electricity to Purkinje fibers, and then conduct the electricity that turns into a mechanical action, which is the contraction of the atria and the ventricle. If in the atrial flutter, there is an extra wire, and sometimes due to latency of AV node or a PAC, then a conduction happens through the rapid axis, or the rapid, an extra wire هذا does not follow the track of SA node, AV node, bundle. It just go between the atria and the ventricle. And as all of you know, each chamber and each segment of the heart has its own automaticity and rhythm. Sinus node usual rate is between 60 to 100, AV node 60 to 80. You don't need to know the number, but each segment has its own rate. And the usual, the way to describe the AV node, it's like a bounce back. واقف على الدور of the ventricle and prevent extra heart rate to come through, and regulate and slow down a beat that is coming from the sinus node, slow it down to prepare it to go to the ventricle. When this system fails, i.e. having an extra wire between the atria and ventricle, it will conduct faster and in a more chaotic and rapider than the usual way. And this is what happens in atrial flutter specifically. The atrial frequency, if you calculate it, which is between the 2 peaks, as you can see here in this ECG, ranges usually in the rate of 300. Ventricular rate, because as you know, despite that the conduction happens in the extra wire, the AV node try to slow down. So sometimes it reaches to the degree of blocking it. And that's what slows down the heart rate. If the conduction happens 2 to 1, i.e. division of atrial contraction to 2, so the ventricular rate will become 150. Why it is 150? Because every 2 beats of the atria conducting 1. That's why you divide it by 2. And that's when you see the sawtooth appearance of ECG. Can you mute the mic, please? Whoever is opening his mic. So every 2 beats in the atria conducting into 1 ventricle, causing a heart rate to be 100. And it usually is a division of numbers. So if it's a 3, it will become a ventricular rate of 100. If it is 4, 75. Sometimes due to either medication or due to abnormalities within the conduction system, it can have a variant conduction. And that's one of the rare incidents where atrial flutter turns from becoming a regular rhythm into becoming irregularly irregular. So it's one of the rare instances where you will find irregularly irregular heart rate that is not AFib, as I told you. Okay. The usual management for these patients, if they are acutely ill, i.e. in shock, you follow the ACLS protocol again. So you shock them by electrocardiac cardioversion, and you sedate, obviously, the patient and shock. And usually you have to synchronize your shot because you want to prevent the QNT phenomena, which can degenerate the rhythm into more malignant one, like ventricular fibrillation or ventricular arrest. Beta blocker is also an option for these patients to slow down the rate and block it enough to slow and to allow the normal conduction through the normal pathway. Also, you can use antiarrhythmic drugs. You don't have to know this at this level, but antiarrhythmic can be used in atrial fibrillation. This arrhythmia is very refractory to medication. This is something you have to know. It's hard to treat on only medication. And the best available treatment in 2020 nowadays is ablation, where they go inside the heart and find that extra wire by measuring it through radio frequency, and then they ablate. They just make a burn through that line or through that wire and cut it, and i.e. cure the disease. And it has a very good success rate of up to 95%, which can be augmented into 97% in certain centers and certain expertise. The same rules that applies to atrial fibrillation in terms of anticoagulation applies to atrial flutter. So if the patient has atrial flutter, you should give him anticoagulation based on the score we're going to discuss in the next few slides. Okay, so atrial flutter is just a summary. So it's an extra wire. It conducts through the extra wire and causes the ventricle to conduct based on that heart rate and based on the block provided by the AV node. If it's 2 blocks, it will be 150, because it's rare instances where you would have a heart rate that is conducting 1-to-1, and that would become a ventricular fibrillation, because a heart rate of 300 is usually fibrillating waves, not tachycardia even. Multifocal atrial tachycardia, it's good to know about. If it distracts you or it causes confusion, just forget about it. But it's good to know that there is an entity called MAT, multifocal atrial tachycardia. It is something in between an atrial flutter and atrial fibrillation in terms of a regular rhythm, where you would have a certain criteria to meet for this type of arrhythmia. You would have a variable waves that conduct from different, the atria has different foci of electricity that conduct into the ventricle. The usual association that you have to remember, MAT is pulmonary disease. MAT is a pulmonary disease. With MAT or multifocal atrial tachycardia, usually there is a pulmonary disease like advanced COPD. Why you have 3 morphology of P wave? Because, as I said, the focus of electrical generation happens from 3 different or even more focuses or foci in the atria, which lead to different morphology. One will be positive, one is peaked, and one is wide, depending on where it is from the atria? Is it from the high left atria, from the base of the left atria, from the right atria, near the AV node, or far from the AV node? Atrial fibrillation, it's by far the most common arrhythmia that you'll ever see in your life, and you should know it hard from A to Z about how to manage and how to recognize, most importantly, and what it is important implication of having atrial fibrillation of the heart. It is similar to atrial flutter. However, the fibrillation or the atria contract at a fibrillatory waves or fibrillatory rate, meaning that it doesn't contract, it's just fibrillate, it dances at usual rate of 400 to 600 beats per minute. Okay. I just realized how to mute all, so I just did that. So the fibrillation that I need you to know, it's the most common disease and the most common electrical abnormality that you will see in your in any abnormal heart rate you'll see in the rhythm. And the most, if you have a question in the exam that says an irregular heart rate, it is atrial fibrillation 99% of the time. 1% of the time it could be MAT or atrial flutter with variable conduction. Okay? Atrial fibrillation as a disease can be classified in different variety of way. It can be classified on that it is usually happens less than 7 days of onset and usually terminates without intervention or spontaneously or with a small dose of beta blocker. Small dose of beta blocker, and it's called paroxysmal AFib. If it lasted more than 7 days, then it's persistent AFib. If from 7 days to 12 days, this is just nomenclature. So it's not really important to know. That you should know that there is AFib of different types. But كلهم at the end, the same disease. It's just the duration that's important because it can impact your management on the long term. And the most important among all of these classification, the non-valvular AFib. What do you mean by non-valvular AFib? Because it will impact your choice of anticoagulation. Because most AFibs need oral anticoagulation. Some medication are not to be used for valvular AFib. So knowing the non-valvular AFib, which is here, it's mentioned, the absence of rheumatic MS, prosthetic heart valve, or mitral valve repair. These three conditions makes the usage of a newer generation of anticoagulation, اللي هم DOACs or the NOACs, novel oral anticoagulation, or direct oral anticoagulation, the DOAC, cannot be used in these three conditions. If you have rheumatic AFib and rheumatic MS, if you have AFib and prosthetic valve, if you have AFib and mitral valve, these three patients should not get a DOAC or a NOAC. They should get warfarin instead, because studies have been shown that the usage of this newer generation can cause thrombosis, and it's not good for these patients because they have high burden thrombosis. This is a class also been used to classify how it is impacting the quality of life, because atrial fibrillation, and that's usually what I tell my patients, atrial fibrillation as a disease does not kill patients. It does not cause problems. The only thing that you should know about atrial fibrillation is that it can cause a stroke. Controlling the heart rate, it's an easy job. Just a beta blocker and the heart rate will slow down. The most devastating sequelae of atrial fibrillation is its impact on stroke. And it can cause a stroke, which can actually disable someone from his routine activity. On the other hand, which can be easily managed, as I mentioned, with medication, is the CCS scale for functional capacity and in the impact of quality of life. The reason we use this scale to determine which patient benefit from ablation, or is the medical treatment is enough, or adding the patient into treatment. So when you look at the atrial fibrillation, you have to look at these three arms: rule out the reversible causes. Reversible causes of AFib are rare, and usually it's just a situation that the patient is at, but the patient has an underlying dilated atrium that can turn into atrial fibrillation easily. Hyperthyroidism is a case where treating hyperthyroidism will reduce or sometimes even cure atrial fibrillation. However, this patient is more susceptible to have atrial fibrillation in the future. Peri-op, during stress, drinking too much caffeinated drinks in a patient who is susceptible to have atrial fibrillation will definitely have atrial fibrillation. Hypertension, chronic hypertension, especially when left untreated for a long period of time, will make, because in all the studies it's been shown that the most common and the most frequent risk factor of having atrial fibrillation is being hypertensive. So having hypertensive is by far the most reason to have atrial fibrillation. So try to correct and reverse these causes if possible. PE also, we've seen a lot of reversible or a lot of initial presentation of PEs with atrial fibrillation. Then you have the arm of managing the arrhythmia itself, and then discussing the prevention of thromboembolic event, which is the most important segment of treating AFib. Management of the arrhythmia, there is two strategies. There is the rhythm control versus heart rate control or rate control. In multiple studies have been shown that there is no difference between choosing both arms. Yani, a strategy of rhythm control is as good as in rate control. However, in certain, if you can convert the patient to normal, which is the rhythm control arm, then this is good and well. Why it's good? Because converting the patient into a rhythm that is normal will make his incidence of having a thrombus in the atria is less. And even now, there is a new study published in the European Society of Cardiology stating that the fastest way, or the faster you convert the patient rhythm, the longer he will stay in his atrial fibrillation, in his sinus, away from atrial fibrillation. So it's beneficial in certain population. However, there is no difference. No one will put you at fault of choosing rate or rhythm control. Rhythm control comes with its downsides. Rhythm control, it can be from electrical cardioversion, which has its own risk, and it's painful, and you need conscious sedation, you need monitoring. It's not easily done. However, in certain emergency situation, it's the only solution, and you have to do it. The other option is antiarrhythmic. Antiarrhythmic for rhythm control itself, the antiarrhythmic drugs are arrhythmogenic drug, can degenerate and can put the patient at risk of more serious arrhythmias. And it has a lot of side effects. The rate control, on the other hand, almost every patient will, at some point of his life, will be on a beta blocker. It's a very common, you know the dosage, it's easy, safe, and benign. If you can control the heart rate, especially in young people with AFib, if you control the heart rate enough, you will convert them into sinus by just controlling the heart rate. And you will see it with young people presenting with AFib, and you choose a rate control strategy by giving them beta blocker, but yet they convert into sinus. So this is common phenomena, specifically in young normal left atrial size heart. The conditions where you would want to choose or favor rhythm control, or even DC cardioversion as an arm of rhythm control, is when the patient is in heart failure and he needs that extra 10 ml of ejection from the sinus kick of atria, or we call it atrial kick, in his cardiac output. When the patient is in heart failure, refractory heart failure to treatment, and he is requiring oxygen and it's difficult to treat, maybe converting the patient into sinus can help the heart failure symptom to get better. Or if the patient is hemodynamically unstable, it can also be an indication to choose or to favor the rhythm control over the rate control. The other thing is if the patient is symptomatic, some especially young people are annoyed by having an irregular heart rate. It's just annoying. That could be enough reason to consider the rhythm control. And stepping up the ladder here, but it's not as good as atrial flutter, ablation could be an option. The technology is evolving, yet the success rate range, in the old days, it used to range between 75% to 80%. Nowadays, the technology is getting better and better, reaching 85 and even higher in certain centers and certain operator. Atrial fibrillation, it's an option for certain patients, specifically or usually young people, where they go, how do they do the ablation? Just quickly, they go through the atria from the venous axis in the groin, in the right ventricle, then right atria, and then they puncture through the intraatrial septum into the LA, left atrium. In the left atrium, they found that the most of the source origination or the origin of atrial fibrillation come from points around the pulmonary veins, pulmonary vein root, and then go there and they ablate. It's a good option, as I mentioned, for certain selected group of patients. The most important thing that I want you to remember, because whenever you have a patient with AFib, لما تديني هو في past medical history, you say patient has AFib. I'm going to mention the score now, scoring system we use. It's called CHAD score. I'm going to discuss it in details, and you have to know it by heart. CHAD score, it's the scoring system that we use for anticoagulation to determine if you anticoagulate the patient with aspirin or with more potent anticoagulant like the DOAC or the NOAC or warfarin if the patient cannot take the DOAC. The second important information, and in addition to having to mention if the patient anticoagulated on aspirin or not due to this XY reason, you have to mention rate control or rhythm control. So I'll give you an example. This is 28 years old man, non-hypertensive, AFib. لازم تديني الجملتين هذه بعد الAFib. ما تقول AFib وستوب. زي ما الانسولين. When you say diabetic on insulin, diabetic on oral hypoglycemic. If you're doing cardiology and if you are into cardiology, you have to give me more information, specifically when you're doing a consult that is related to the presentation. So you say atrial fibrillation on rhythm control and oral anticoagulation. That would be a good presentation that you understand the impact of this disease, that it's a rate and rhythm control issue and then anticoagulation issue, which is to preventive of thromboembolic event. It's a busy slide, but don't worry about it. Just simple, think about what I just mentioned. Rhythm control strategy, rate control strategy. Rhythm control, you use antiarrhythmic. For your level, you don't have to know which antiarrhythmic because there is a variety of choices. However, just say antiarrhythmic as a rhythm control strategy. You can even consider shock as part of the rhythm control strategy if the patient is symptomatic and in heart failure. Heart rate control, on the other hand, it's easy. Just aim for a heart rate less than 100 at rest or less than 110 at exertion or activity. The usual is AV nodal blocking agent like beta blocker or calcium channel blocker. Okay. This is part of the ACLS protocol, which I'm sure all of you have done it. And if not, you're going to have to do it soon for clinical years because you have to, whenever you're in the hospital, you have to be part of the ACLS team and to be able to identify the rhythm and treat accordingly. So this is just when to ablate or when to use DC cardioversion for patient presenting with emergency. Again, it's not that important to know the duration, only know the indication of atrial fibrillation, cardioversion, and that only happens for certain choice of patients. If the patient is symptomatic or heart failure, there is a sequelae of choosing to cardiovert them now or not, because if the duration of atrial fibrillation is less than 48 hours, then theoretically the clot has not yet formed in the atria, so you can cardiovert them into sinus without the risk of thromboembolic event. If it's more than 48 hours, you should not DC cardiovert because this increases the risk that if this patient has a clot in the left atria, then it migrates into the brain and cause a stroke. So this you need further workup to make sure that this patient does not have a clot, and you should initiate anticoagulation for both group. For the population of more than 48 hours of atrial fibrillation, a TE is usually indicated to show if there is a clot. If there is no clot, you proceed and cardiovert. If there is a clot, then you anticoagulate and bring them back again and check if they have a clot, because always the risk when you cardiovert someone from atrial fibrillation, the risk of if there is a clot in the left atria, it will migrate into the systemic circulation, causing stroke, ischemic bowel. It can cause even a STEMI if it migrates into the coronary arteries. What's a CHAD score? CHAD score, here there's a CHAD VASC, it's even higher, but if you know CHADs, that's more than enough. CHAD stands for C, it stands for congestive heart failure. H, it stands for hypertension. And just going back for the congestive heart failure. Congestive heart failure, if you have history of shortness of breath or documented pulmonary edema on an X-ray, that's enough to make it to take that point. So you don't have to have a low EF of 35% to make this patient a CHAD 1 or taking a point from the C. So only history of heart failure or pulmonary edema can grant you the point. H is for hypertension. Any patient with hypertension take a point. D, it's diabetes. S for stroke. Why it's 2? Because stroke takes 2 points. So if the patient is diabetic, hypertensive, and congestive heart failure and a stroke, he take a CHADS 5. For each, take 1, except for the stroke where he take 2. Why it is important? Because the higher the CHADS, the higher risk of stroke. You don't have to know the percentages, but it doubles usually. If it's CHADS 1, it's a 2%, 2, it's a 4 to 6% of annual risk of stroke. This risk decreases to near normal with anticoagulation. And that's why it's important to identify these patients and try to treat them as early as possible. Again, here's the summary of what I just mentioned, congestive heart failure. By history, you don't have to have an echo to document that. If you have an echo, an EF less than 40 is needed for 1 point. Hypertension, 1 point. Age more than 75 is also a point. Diabetes, 1 point. Stroke and TIA and thromboembolic event makes 2 points. And you can see here and to the right of the table that the risk increase by the numbers up to 18%. Can you imagine that you have an 18% of risk of stroke per year that can move down to 1.9 with anticoagulation? So anticoagulation is highly warranted in this patient population. And this is if you know the extra. If you know 1 is enough. CHAD VASC, they just studied more, included female, included vasculopath patients, and they have the same strategy. I use CHADS because it's easy and easy to remember. So choose whatever you like. However, you just need to know the risk of stroke is higher the more points you have. There is, on the other hand, if you anticoagulate patients, they will tend to bleed. For complicated patients, you don't need to know the specifics of this risk bleeding score, but know that there is a mirror score that we use to anticipate the bleeding risk of patients. And then you discuss it with the patient. You tell them, I'm going to start with anticoagulation on the basis that you have a CHAD score of 4 with a risk of stroke of 8. However, your has bled, it's called has bled score, is also put you at risk of bleeding by 8%. So then the patient is at choice, and into 50-50%. You either die from a stroke or die from bleed. And from my experience, majority of patients don't mind bleeding because most bleedings can be reversed. Most bleeding can be corrected unless it's intracranial where it's fatal. So it's always in these high complicated patients with the score here. I don't want you to know it. It's not important. Just know that there is a score that is mirrored to CHAD that can anticipate the bleeding risk of the patient, which make you counsel the patient when you talk about anticoagulation and know in which group he will lie into. Low risk group, then the anticoagulation is justified. And even you want to push the patient to be anticoagulated. But when the patient is at higher bleeding risk and higher stroke risk, then you have to tell them then this is the best option for you, is to choose what suits your life and what to anticipate from it. There is, it is well established, but yet experimental. وموجود في السعودية. It's a device that occlude the left atrial appendage. It's a percutaneous surgery that we go through the groin into the left atrial appendage and occlude it with a device that can hinder the patient low risk. يعني it will minimize his risk of stroke because most of the clots that form in atrial fibrillation is from the left atrial appendage. And theoretically, if you occlude that left atrial appendage with a device, you minimize the risk. So the high-risk bleeder and high-risk CHADs, they are getting this device to block the left atrial appendage, and then they just take aspirin. They don't have to take the high risk of bleeding as per the Hasbled score. This is also something you have to know. The first three letters, or the first three rows of this medications, you should know, because these will come to you. A patient taking one of these medications. Available في السعودية dabigatran ولا viroxaban ولا bixaban. Edoxaban is not yet available. They are a category of direct oral anticoagulant, novel oral anticoagulant. Each work differently, but they have the same. Like the dabigatran, or Dabi for short, the mechanism of action is direct thrombin inhibitor. The rivaroxaban, or Xarelto, the commercial name, it's a direct factor 10A inhibitor. Same for the bixaban, it's a direct factor 10 inhibitor. This medication came to replace the warfarin. Warfarin is very painful drug to take. Why? Because with warfarin, you can't take green leaves. You have to be on a certain diet because it interacts with many foods that you might like or eat. Warfarin needs the blood, at least initially, in the first few months of taking it, you need weekly or bi-weekly INR level to determine the right dose for you. It interacts with many drugs, including antibiotics, and can cause elevation of the INR. And it has a window, of therapeutic window, that is need to be respected and monitored. These drugs do not need monitoring, and we know when you take the drug, you are anticoagulated safely. And actually, it's been studied, compared these drugs with Coumadin, and it showed that it's actually these drugs better than Coumadin in all regards, in terms of ischemia, in terms of clot prevention, and in terms of bleeding. Even they bleed less, because with Coumadin, it has a chaotic range, and sometimes it can make you over anticoagulated and bleed, or it can make you under anticoagulated and then have a thrombus. It's actually one of the best new treatment that came into the market recently, and most patients take them. However, you have to know and tell the patient that until now, although in Canada and North America, they do have an antidote, they don't have an antidote for this medication. The reason is that if the patient comes bleeding from a motor vehicle accident, or he's needing surgery urgently, he is at high risk of bleeding, because we can't reverse the effect of this drug. Again, nowadays we do have a reversal agent, and it's, I think, coming to Saudi Arabia soon. So it will be available to the hospital in emergency situation, where you can give this antidote to reverse them, specifically for emergency cases where the patient is going for surgery, or he has bled into his head, or coming with a massive bleeding. The Coumadin, on the other hand, it's easily to reverse. You just give vitamin K and sometimes fresh frozen plasma with factors that is depleted by the Coumadin, and then you get the patient not bleeding in few hours of the infusion. These drugs are magical, as I said, and once we have the antidote, it's actually the best treatment you can ever have for anticoagulation of atrial fibrillation. Okay. Again, you have to remember that these patients اللي ذكرناهم في البداية, a non-valvular shouldn't take it, because they studied it and they know these patients at higher risk of thrombosis. So the rheumatic mitral valve repair, prosthetic valves, specifically the mechanical valves, they should not get this. They should just stick to the good old Coumadin, and it's unfortunate for them they can't take this medication, but because of harm, because taking this medication will make them thrombose more, and it's not safe for them to take this medication. So the only exception, it's all the patients except these three. Of course, you have to respect also the creatinine clearance and the age, and this is more into details on to which group you give the medication, but this is, again, not important for your level, but know that there is an indication and there is dosing differences for different patient population. Okay. Last two arrhythmias that you should know. It's part of the ACLS, and it's ventricular tachycardia. To be able to call it ventricular or sustained ventricular tachycardia, it has to be more than 30 seconds in duration, with 3 consecutive complexes at a rate of 110 to 250. One of the cardinal features to identify ventricular tachycardia as compared to an aberrant conduction, i.e. sinus, but taking fast heart rate, is when the patient have AV dissociation. This by itself, it's so deep and it has a lot of like pathway. You can read more about it in Brugada's pathway to differentiate VT with supraventricular arrhythmia with apparency. It's not within the scope of this lecture or your level to know how to differentiate it. All rhythms that come similar to this in the screen is ventricular tachycardia and treat it as such. Okay. Acute management for such condition usually is if the patient is stable, you have time, you can give medical treatment by antiarrhythmic, either procainamide if the patient is ischemic, or amiodarone. The usual, it's a loading dose followed by an infusion. And if the patient is not responding or unstable, then shock the patient out of it, convert him to rhythm. The most common cause of this type of monomorphic VT is car-related, i.e. ischemic heart disease related. So this patient needs ACS management if he's coming with chest pain, and needs a coronary angiogram to evaluate his coronary if he did not have one or he's not already known as an ACS. There is a specific type of arrhythmia that it's called Torsade de Pointes, which mean tachycardia turning around an axis. And it's usually related to abnormal prolonged QT, and then it gets so prolonged that it converts into this type of ventricular tachycardia. So when you see it, it's Torsade de Pointes, it's polymorphic VTAC related to QT interval. How to treat? Consult cardiology. Most of the time, pacemaker can help in these conditions where you override pace the heart to a rate higher than the arrhythmia, then it will convert, or you can give antiarrhythmic and DC cardioversion if the patient is unstable. Okay. Last arrhythmia that is important, and it's actually a pre-death arrhythmia that happens, and when it happens, the patient is degenerating to death, because the next thing to this rhythm is a flat line. It's called ventricular fibrillation. It's when the ventricle fibrillate. Fibrillate means it does not have any contraction. It just fibrillate, i.e. does not inject any blood out of the aortic valve, no perfusion to the brain, to the organ. So the patient is literally dead. So when you identify this rhythm on the ECG or the monitor, immediately start chest compression. You don't need to check the pulse, because you will never have a pulse with this rhythm. You will have death with this rhythm. So according to the ACLS protocol, when you identify this, you start chest compression immediately, and after 2 minutes, you cardiovert, you give medication, you check the pulse. If it's converted into VTAC, then maybe there is a pulse, but with ventricular fibrillation, there is no pulse. And there is the 5 Fs and 5 Ts known causes of ventricular fibrillation. You should know it, because it's reversible and you can treat it once you identify it. The 5 H's are hypovolemia, so give volume to these patients. Hypoxia, obviously extreme cases of hypovolemia, not all hypovolemia will go into ventricular fibrillation, but if the patient is known coronary artery disease and he goes hypovolemic and he is having chest pain, then he might degenerate into this arrhythmia. Extreme hypoxia, hydrogen, which i.e. acidosis, hypo or hyperkalemia can put you into this rhythm, hypothermia also. For the 5 T's, tension pneumothorax, tamponade, toxins, coronary thrombosis, or pulmonary thrombosis. Why they يعني حطوها in an easy 5H and 5Ts to remember them, because when you're conducting the code, knowing these and identifying the diagnosis in this patient can save his life. If the patient has a tension pneumothorax, just decompressing that tension pneumothorax can revert him back to sinus. Tamponade, draining the fluid around the heart, will cure him, or i.e. revert him back to a normal state where you can manage him. So this is life-saving. That's why it's very important for you to know the most common causes of ventricular fibrillation. Pulmonary thrombosis, you treat with thrombolytics. Coronary thrombosis, you send him for PCI. Toxins, you try to dialyze or give antidote. And once they get stable, they return usually into VTAC, and then they get the VTAC management. وهذا وصلى الله وسلم على سيدنا محمد. If you have any questions سواء للمحاضرة الأولى أو المحاضرة الثانية, I'm here. I will stay as long as possible and I'll speak as slow as possible, just for the guys who mentioned no, I was too fast. I apologize, but I'm here to help you. You can reach me by email. You can reach me also via Twitter if you have any questions. If you want to have a session, inshallah, once things open after COVID, I'll be more than happy to give it. Okay. Yep. خلاص كده أظن تقدروا unmute yourself. Do you have any questions, guys? ما أدري وضحت. خليني أروح للشات. Yes, I have. Okay, طيب يوسف. You can open the mic. تقدر ولا ما تقدر؟
ايه اقدر. السلام عليكم دكتور.
السلام ورحمة الله وبركاته. حياكم الله.
دكتور بالله عندي سؤال بسيط بخصوص البيشنت اللي صار عنده مايكارد انفاركشن وسوى ستنت او بالون. كيف الاي سي جي حقهم تكون؟ يعني تكون مثل النورمال بيرسون او التخطيط يكون؟
Yeah, go ahead.
بس هذا سؤالي دكتور.
انه التخطيط يتغير بعد المايكارديال انفاركشن، يعتمد على نوع الانفاركشن they got. If they got an ST elevation MI and you save them in time, يعني ما خليت المسل dies or get dysfunction, then the ECG turn back to normal completely. However, a majority of patients will either come late ولا انه يصير already damage that you can't fix. ففي evidence of Q waves usually that gives you a hint that this patient had an MI. A pathological Q wave, because some people have normal Q wave. A pathological Q wave is deep and big. Just to know, there is a certain numbers. It's more than one small square, and the depth is more than 5 or more than half of a large square is a pathological Q wave, and that usually indicates an irreversible damage that happened to the heart. Hopefully this answered your question.
واضح يا دكتور، الله يعطيك العافية. شكرا.
يلا شباب، أي سؤال ثاني؟ إذا ما عندكم سؤال enjoy the weekends، وزي ما قلت لكم I'm available at any time. أي واحد interested في الكارديولوجي حيا الله. بالعكس we encourage more cardiology. We need more cardiologists actually because it's the most demanding specialty وعندنا a lot of need في السعودية. موفقين إن شاء الله. يلا we'll end up the session if there is no more questions. يلا فمان الله، بالتوفيق يا شباب.